lecture which is important. Okay. About the lecture abnormal uterine contraction, which is important. Why? Because this material in your DUTA book is not given so nicely, and classifications which is given in DUTA are not accepted at all, because it's mixture of different things like Russian salad vinaigrette. Поэтому please not say for me when you answer for credit or for exam that madam we take it from DUTA. It's not scare me. You need follow my lecture. That's all. Distorция it's a result of one of the term. For that we need to understand terminology, that it's abnormal or difficult labor. Also, distortion associated quite common with operative cesarean delivery. But we have another term which is also use term distortion. For example, you heard shoulder distortion. Так, students, it's Hari Priya, for example. Why I need again and again, I need to invite Madame Sharifa that she will be called to you, that you need switch on your video and show for me your face, everybody. Why you need every lecture I need a reply for that. Another term which we have, for example, it's cervical dystocia, when cervix is not able adequately dilatate, and because of that labor processes stop. For example, cervical dystocia and shoulder dystocia, both are dystocia, but one is a dystocia associated with maternal factor, like cervix is not dilated. Hari Priya, what is funny? What is funny? What funny I'm explaining? Can you answer for me? What make you so amusement? I will see how you will be amused on credit or on exam. How we can laugh if you not answer for my questions. And another is associated, like shoulder dystocia, usually with macrosomic fetus, which has big shoulder and it can be obstructed. So in this case, it's or fetal factor or combined factor as a result of cephalopelvic disproportion. But term in all these things we use dystocia, general, difficult, abnormal labor, and can be used for obstructions from cervix or from fetal part. Remind for you that for labor we have 5 main P points which associated with normal process of parturitions. It's power. Power, it's abnormalities of maternal expulsive force, normal or abnormal. If we say by simple words, it's contractions. Power is contraction. Passage is problem with pelvic structure, and here it might be as a result of narrow pelvis. Passenger, it's fetal cause, and as I told already, it probably can be big or shoulder big, or disproportionately big, or symmetrically big fetus. Another positions might be size of the fetus normal, but it's situated in malpresentations when extended fetal head and diameter by which fetal head delivered is bigger than normally. And psychological last factor, it's mean how mother responds for the labor, how is adequate or not adequate, communicate, how she listen doctor when necessary to push fetus, when necessary to stop pushing. So this is psychological factors. For example, I maybe already gave for you the story when one girl everything normal. She's young, normal contraction, cervix normally dilated, but in the moment when she need push and we request her to push, she start cry, jump from the obstetrical table and start run around the obstetric delivery room. And in this case, we doesn't have any possibility to deliver her normal way. So we give anesthesia and apply forceps for delivery. So psychological factor is also very important. Communications of mother and doctor staff. It's like students able to communicate or not. I told show your face for professor. Да, you show for me your window, your wall, your ceiling, everything as possible, but not your face. What, for example, group number A, Ashadi, Apsara. Where is your face? Only ceiling, да? I can see. What? Can you make camera proper? I think it's possible. So please, everybody check. I want to see your smart face. Smart. Так, Friedman curve we use to analyze adequate or not adequate process of cervical dilatation and descending of presenting part of the fetus. Also, we understand that it's different according, time is given different according, is it a nulliparous or multiparous. So obligatory, we need know in diagnosis it's necessary include, and for which reason maybe you think we are curious that we put she's nullipara or multipara. It's necessary, for example, like here you can see how many times we are able wait and give for a normal delivery for any woman. For example, latent phase for prolonged latent phase associated with nulliparous more longer 20 hours, for multiparous only 14. The same protractions disorder can be in this case. We calculate how frequent, how fast occur cervical dilatations, and we know that for nulliparous it need be 1.2 centimeter per hour. For example, we check cervix normally. Who can answer for me how frequent we need to check cervix during labor? Which interval? Group number 4, Kakaniджи Удуди. Can you say for me how frequent we need do cervical examinations? Switch on mic, please. Can you say or not? Can you say for me something? I not hear your voice. What's happened? Talk. I'm not able to hear you. Так, impossible, да? With you communication impossible. Very good, very good. Так, group number 1, Marietta Lapanstisha, you. Show for me your face, and not only your forehead, and answer for the same question. Switch on your mic. Switch on your mic and talk. Алло. Answer, do you know?
Every 5 to 7 minutes.
Who knows? Several person who already finished. We already second semester. This topic we discussed when you was first semester. How you going do credit? How you writing case history? Who able to say? I'm still waiting.
Every 2 to 3 hours.
Every 4 hours.
Okay.
Perna busy, group number 6. Where she is? Prerna busy. Empty room. Так, monitor of group number 6, please put for this person absent. Who is monitor?
Ma'am.
Aga, you decide come back? My dear. Why you not listening lecture? Switch on mic and show for me your face. Switch on mic and show for me your face. How many times I need request you, Prerna, group number 6?
Yes, ma'am.
Switch on your mic and switch on your video, not your hologram. Why you not on the lecture? Prerna, explain for me. She disconnected at all. Так, monitor, please put for her absent. If she not able, follow my not present, come back. Так, every 4 hours we need do vaginal examination. Monitor, are you here? What I told? Who is monitor of group?
I'm here, ma'am.
Here. You listen?
Yes,
Heard
ma'am.
what I told? Absent. Why? First, empty room. After only I start scream, she come back and not able even to communicate with me. Значит, my dear, I already tired when you show for me your antique lecture and say that, madam, it's from your lecture. And demonstrate for me lecture, which was 2008 or 2010. It's old lecture. Поэтому please listen and write new material. And if we compare cervical dilatation after 4 hours, it need be dilated, multiply 1.2 centimeters for 4 hours. How many centimeters it will be? Minimum 4, да, centimeters need be dilated after 4 hours if we have nulliparous. Multiparous woman has cervical dilatations more faster. It's mean 1.5 centimeters. So after 4 hours, it will be dilatations already 6 centimeters. Prolonged acceleration phase occur if we have 7-10 centimeters till 7-10 centimeters, 3 hours or more for nulliparous, and for multiparous 1 hour or more. Secondary arrest of dilatation. What does it mean? In beginning, contraction was normal, dilatation of birth canal was normal, but after that, something occur and cervix not dilated normally. It might be exhaustion of patient, might be problems with cervix, might be cephalopelvic disproportion. You need to find the reason and find decisions for that, because secondary arrest of dilatations, it's obligatory need check, rule out CPD, cephalopelvic disproportion. Protracted descent, we have dilatation and descent, true curve, Friedman curve. So another parameter which we analyze is how fetus descend, and it also can be protracted. It means descent, but descent not enough, not with adequate speed which we expect in normal condition. Speed is also different for nulliparous and multiparous. Or might be arrest of descent when it's stuck and not descent at all. And additionally, we have here is no big difference for primipara or nullipara. It's prolonged second stage of labor. 20% of women has abnormal labor. But if we find who is more common is primiparous woman. То есть majority of them, 80%. Multiparous already not so common. And characteristic of power is important. Analyze if we check contractions and deviations. What is when we discuss abnormalities, we need to remember normal. This lecture already was given about normal parameter. I deliver for you normal uterine contractions, but remind again for you normal criteria. If deviation of each of that parameter, it will be abnormal. In different type according classification, we might have different combinations. For example, intensivity is greater in the fundus. It's normal, but допустим, if we have opposite intensivity more bigger in low segment, in that case we have contraction with abnormal uterine polarity. Another term which we are able to use is uterine polarity. Average 24 millimeter hydrargyrum tonus of the uterus. Uterus always has tonus because it's muscle organ. Muscle organs always has tonus. But if tonus decreased or increased, as a reply, we can have or poor contractions or opposite intensive contractions. It might be increased. Contractions need be well synchronized. If we have well synchronized contractions, it's contractions with normal polarity. Group 6, Varshita Varma. What is fun you have? With whom are you talking? Repeat, please switch on mic and repeat what I told just now. Switch on your mic and answer. Switch on your mic and answer. You're not on mic. How to talk with somebody you and laugh, you have enough possibility to do, but how to switch on mic and reply for professor, you are not able. Okay, I will wait. Everybody will wait before you switch on your mic. Varma.
I'm here, ma'am.
Да, you here. Explain for me, please. What's funny things are you doing during my lecture? Laughing, talking with somebody. Repeat my last sentence, what I told, how intensively you listen me. Not able. Because you not listen me at all. Who is, when you already finished your obstetric class?
Yes, ma'am.
When? Так, значит, another parameter is frequency and durations of each contractions, which with but even here, not respect teacher. Teacher ask, you keep a silence. You ignoring even answer. How you think? What do you think? Will we be the same good attention for you if your behavior like that? Another contractions need be regular and rate and force of contraction we need have adequate. Basal resting pressure is 12-15 millimeter hydrargyrum. Time of resting, as I told, is obligatory, and basal tonus in that period still present, and it's around 12-15 millimeter hydrargyrums. If during contraction in the maximum peak intensivity might be reached till 35 millimeter hydrargyrums in first stage, or even till 70 millimeter hydrargyrums in second stage, because the intensivity increase with the stage. And duration, what is duration? Duration from beginning till the end of contractions. With normal progress of labor, duration of contractions increase, interval between contractions decrease. То есть contraction become more frequent. Another things about which we need to remember is triple descending gradient or normal polarity. This material is absent in your book, so again remind for you, be attentive. We have pacemaker because uterus is very familiar with heart and also has a pacemaker which initiate contractions, and that contractions is descend from top of the uterus because localizations of pacemaker usually tube uterine angle, so maximum intensity of contraction is in the fundus. If we divide uterus for three parts, fundus, body, and segment, maximum it's in the fundus. In fundus it started earlier, it's stronger, and duration of contraction is longer compared with part which is situated below. Phenomenon of triple descending gradient was discovered when investigate external external topography, multi-channel topography, also remind for us ACG for registration of normal heartbeats, and when apply transducer in the different part of uterus, they find that in fundus part it's longer, stronger, and more intensive compared with part which is below. For example, here you can see how it looks schematically and how it looks on cardiotocography. On the cardiotocogram 1, 2, 3, 4, 5, this is external waves, and one is summarized from internal topography, which is introduced through the vagina inside uterus. And we see that, for example, here, you see how my mouse move or not? Are you able to see movement? See that? Here is a fundus part, and intensity of contraction is bigger compared, you see down here, wave is from a low segment. It's much more intense. We can constatate that contraction is intensity and polarity is normal. And here summarized, we see regular contraction with normal intensity, with normal resting period, with normal durations. So here we can see on tocogram normal contractions and normal polarity according. No, if polarity is normal, contraction usually also normal. What does it mean, abnormal uterine contractions? Any deviation, as I told, from normal parameter, all parameter I gave for you, which can lead to abnormalities of labor, we call abnormal uterine contractions. Classifications, we divide for two main groups, normal polarity and abnormal polarity. With normal polarity, contraction can be with big intensity. We call it hypertonic. With polarity normal, upper segment is contracted longer, stronger, and like that. But intensity of contraction is bigger. Hypertonic contraction. And opposite situation when we have, from the first opinion, with normal triple descending gradient, but intensity of contractions is decreased. Also with hypotonic contraction might be more longer resting period, with hypertonic shorter interval between contractions. It's more frequent in hypertonic and not so frequent rare contractions with hypotonic. Hypotonic we able to divide for several parts. First is pathological preliminary period. Today I already talked about that. It's different according time for primum and multipara. In another uterine inertia, and it can be a uterine inertia primary or secondary. Primary uterine inertia, it's from beginning, contractions weak, poor, not adequate from beginning of it. For secondary, we call it quite common tired. Primary uterus, it's lazy uterus, like student. There's some students is lazy, so we can say lazy uterus. Secondary uterine inertia, it's like professor already tired, да? So many jobs, so many work, and sometimes can be exhausted from that. Поэтому secondary uterine inertia we call that it's a tired uterus. Abnormal polarity, it's a really big problem for doctors because так, где тут вот так, да? We have three main type of abnormal polarity. About first, I already told little bit reversed uterine polarity. In that type of abnormal contractions, we have upside down triple descending gradient. The maximum strong contraction we have in the low segment. What we have as a result of that? Who can say? Any idea, students? You had already lecture before, you had classes. Who knows? Even
The
today,
descent will be slowed down.
not. What we have as a result of normal contraction? What is the main phenomenon?
Dilation of the cervix.
Dilatation of the cervix. Here, opposite, because low segment maximum contraction, so we have constriction of cervix. How we call terminology? Which terminology we use here? I start lecture from that.
Dystocia.
Dystocia. As a result of that, we have cervical dystocia. In your duty, it's given as not as a result. It's given as abnormal contractions. It's not abnormal contractions. It's result. It's as a result of these abnormalities, and not general, especially more frequently is associated with cervical dystocia, more frequently associated with reversed uterine polarity. Another situation, we have localized tonic contraction when contraction ring, which is situated in the middle, the middle part of the uterus, contracted more stronger. Upper part fundus and lower segment is as a result of this, uterus has shape of cent clock, and also no progress of labor. It additionally it can be risk for hypoxia because can be in the region of neck compression by the uterine muscles for fetus, also dangerous. And вообще not organized contraction, it's contracted as one generalized tonic contraction, asymmetrical uterine contraction. I call it crazy uterus, which is do anything what it wants. Так. Да что ж такое, вот оно. As a result of uterine reverse polarity, we have hypertonic low segment, as I showed. As an localized tonic contraction in the middle, we have pathological contraction ring. And as a result of a symmetrical contraction of uterus, we have tetanus or colicky uterus. Что такое colicky uterus? It's clinical symptom. And majority of these abnormalities, especially hypertonic low segment and contraction ring, can give additionally no progress of labor, and opposite for expected normal cervical dilatation, we have cervical constrictions, or we call that proper term, cervical dystocia. And additionally, for normal uterine polarity, we have weakness of expulsive force. If all what I took before was associated with the first stage of labor, expulsive force, it's a moment when we have second stage of labor. And in this case, we have two factors. If in first stage of labor, mother not participate in process of labor significantly, in second stage, we have combination of factor. Maternal effort, psychological maternal, physical maternal, plus also contraction. Without contractions, good adequate contraction, we are not able to expulse fetus. And if a weakness of maybe good contraction in beginning enough for cervical dilatation, cervix dilated till normal 10 centimeter, but suddenly mother exhausted, tired, so that's all contraction. No contraction or not adequate. But here we need maximum effort because to push fetus from the birth canal, it's need enough energy. And in this case, for sure, we are not able, mother not able to deliver spontaneously. And here might be indication for applications for delivery by which method? Which method? C-sections, not necessary C-section. If cervical complete dilatation, we can apply vacuum or forceps. No, preferable is vacuum. Так, also we have some classifications which is given for us according nulliparous, multiparous. About latent phase prolonged we talk already. About active phase, because we dilatate according stage and also dilatate according latent phase, active phase. But latent phase is abnormal if it's more than 20 hours for nulliparous and more than 14 for multiparous. Active phase abnormal if for nulliparous it's more or less than 5-8 hours, and for multiparous more or less than 2 and 5 hours. Why I say more or less? Because if more, we have which type of labor clinical? Who able to say?
Prolonged labor.
Prolonged labor, yes, we have prolonged labor. In the case if it's shorter, we have which type of labor? How we call fast labor? How we call? It has term.
Precipitous?
Precipitated, correct, precipitated labor. So abnormalities, as I told, deviation in one or in another way can give abnormal labor. Somebody can say that fast labor maybe think is good, easier, fast is the easier for mother finish, they're not necessary be in labor so long time. But it's not correct because the more fast is dilated, the more risk for maternal birth canal trauma from the one hand, and from another hand, it's trauma for fetus because fetus passing through the birth canal without any adaptations and not maybe it's cephalic dementia for fetus also possible. Second stage is according time for nulliparous not longer or not shorter than 2 hours, and for multiparous we give only 1 hour. Third stage, no difference for nulliparous and for multiparous too. Predisposing factors we can divide for maternal, uterine, mechanical, fetoplacental, and iatrogenic. Now a little bit talk about each predisposing factors. Maternal is usually associated with obesity, multiparity, advanced maternal age. But I told that age is not obligatory. If each rules has exclusion. For example, I parallel at the same time plus minus, this girl is young age, and I told about her not adequate behavior, which complicate her labor, and we had problems with expulsive force with second stage of labor. But in case if at the same very close, I had delivery with one woman who was in advanced age. It was her first pregnancy and first delivery, and she want baby so much, so she participate, communicate, she tried do the best as possible. Maybe she can have some physical difficulties as a energy, maybe tired and so, but her mental psychological preparedness for delivery was quite good, and she communicate much more better compared with the young woman. So here is, but it's general, but you need to remember each rules has exclusions. Post-date pregnancy associated with hormonal problems also, because it will be exhaustion, not exhaustion, it will be aging of placenta, which produce hormones, and if post-date pregnancy, hormones already decline. About physiological told, immunodeficiency, endocrine disorder, late onset of menarche also can be as a maternal factor. Now talk about a uterine factor. It can be a scar, for example, from previous cesarean section, or maybe scar from any operations on uterus, like conservative myomectomy, for example, or maybe it's congenital malformation of the uterus. On the 5th year, I will deliver for your lecture about that, and quite common. We have bicornuate uterus or septate uterus. Here might be problems with localization of pacemaker. Some gynecological disease like endometriosis, because muscle of uterus defected or destroyed by endometrioid implants. Or opposite, we can patient can have genital infantilism. What does it mean? Infant, it's a baby. Then she has uterus not mature, and it can be as a result also as a result of hormonal disorder. But it's also a uterine factor. Overdistension of uterus is the most common factor. It can be as in multiparous woman who has, допустим, 5 delivery, 5 times uterus dilated like this. Так, где ты, Varma, group number 6? Again, switch off your camera. What? Why I always need? Что you are princess or queen? Why you always try that my attention will be for you? Why not possible switch on and sit and listen normally? Так, mechanical factors. It's usually contracted pelvis, might be abnormal lie of the fetus, like oblique transverse malpresentations, macrosomic fetus, and deflexed fetal head, like in face presentation or in bro presentations. In this case, formation of CPD, cephalopelvic disproportions, and can be obstruction of labor. And in this case, we quite expected can wait secondary uterine inertia and arrest of the descending, for example, first arrest of descending. Fetal and placental, no, about some part of fetal mechanical we told, but placental associated with problems of fetal glands like adrenal glands or hypophysis, and in this case quite common, it's associated together with post-date or post-term labor. In that case, not adequate production of fetal hormone, which initiate process of parturitions. From another hand, premature or late placenta mutilations also can be affected because initiation of contractions at the same time participate. If you memorize theory of labor beginning, we discussed this lecture and topic in the first semester. We have hormonal theory of labor, and if placenta already old age because of some disease, maybe as an infection, but doesn't matter what's the cause of that, finally placenta not produce adequate hormones. And the most serious is iatrogenic, according to my opinion. And you see here a big list of spasmolytic, tocolytic, anesthetic, sedation, analgesic, oxytocin. And only oxytocin is can cause or for hypertonic or for discordant contractions. Spasmolytic, tocolytic, anesthesia, sedation, analgesic, they usually can, if they do not proper, not adequate dosage, overdosage, or maybe prolonged use, they can increase, for example, latent phase can be as a result of that prolonged latent phase, or they can create hypotonic uterine contraction, normal polarity, hypotonic, and as a result of that, no cervical, adequate cervical dilatation, cervical, we can have arrest of cervical dilatations. According factors, excessive sedations, false labor, no false labor or true labor, you need differentiate, and we talk about criteria in first semester. In my lecture I gave that. Second, it's unfavorable cervix, and if patients artificially doctor won't finish pregnancy, start labor earlier, but cervix still not unfavorable, it's not good result. We in 90% will get abnormal uterine contractions if doctor, for example, perform artificial rupture of membrane and initiate contractions by oxytocin. So here, even if you have post-date pregnancy, I always teach you that first we need to have adequate cervix. Number one, it's preparation cervix adequate maturation. According to what we estimate cervical maturation, who is able to say for me? Which scale? According to which scale we estimate cervical maturations?
Бишопско?
Алло, Бишопско. Конечно, Бишопско. I ask very simple questions. Very simple. And we estimate Bishopsco cervix for beginning of labor need be favorable. And first need have favorable cervix, only after that started contractions. In normal physiological labor, it's occur like this. If we need terminate pregnancy because of maternal reason, for example, preeclampsia, but she has unfavorable cervix, according to Bishopsco, not good. We do rupture of membrane, prescribe oxytocin, but we get abnormalities of contraction. Cervix is closed. Поэтому first proper tactic, prescribe drugs for cervical mutilations. Check when cervix is mature, only after that perform amniotomy. Or if it's not effective pharmacological preparation of cervix, we need to think about another way of delivery by about cesarean sections, like that. Так, uterine inertia is a common type, the most common type of disorder characterized by insufficiency force, to intensivity of contraction is weak, less than 24 millimeter hydrargyrum. And also we have deviations of intensivity of contraction diminished, duration short, intervals opposite increased. But what we have, what help us, how we able to differentiate, is it with normal polarity or with abnormal polarity? Good relaxation in between contractions, or clinical with palpation, or by tachography gave us idea that it's normal polarity. Cervical dilatation present, but it's not sufficient, it's slow. Here I try systemized for you other abnormalities like prolonged latent phase, extent of expulsive force of second stage of labor, and the main characteristic and main causes and management. For example, as I told for prolonged latent phase, already I told for you, it can be excessive sedations. From the one hand, if we have prolonged latent phase, we able give for patient pharmacological rest. This patients need, because she has false labor, by other words, ineffective, non-productive contractions, and mother tired from that. She not sleep, she not able. She need have good rest, and after that, it's quite common, contraction, adequate contraction will restore spontaneously. But if we overdose sedations, it might be prolong this latent phase. So we need no adequate balance of pharmaceutical corrections, not overdose. In some cases might be theta-pelvic disproportions, and here is necessary to rule out, especially if with clinical pelvimetry we find narrow pelvis, and with abdominal clinical methodics with circumference and fundus height, as we teach you, you calculate very fast and find that size of the fetus bigger. To this combination, pelvimetry fetus, one or both bigger, think about possibility of theta-pelvic disproportion. And for that patient might be additionally we in that case can recommend imaging investigation of pelvis. Absence of expulsive force in the second stage. I told about exhaustion of patients, and I explained why is important, because we need, mother need enough energy to expulse. And here, quite common, we use oxytocin infusions, and typical mistake of young doctors that they use, for example, primary uterine inertia, not sufficient contraction, prescribe oxytocin as a treatment for that pathology. Contractions increase, and cervical dilatation with the help of oxytocin sufficient, cervix dilated, and doctor stop infusion of oxytocin. And here very fast become contraction again, decline. Why it's like this? Because of oxytocin, it has very short time of effect of oxytocin, very short. So stop and effect is finished. But for expulsions, we need even more energy, more contractions to push baby through the birth canal. So here, not necessary in such conditions, stop oxytocin. Sometimes we have normal physiological without oxytocin first stage of labor. In second stage, for example, mother exhausted and not enough energy to expulse fetus. Might be also infusion of oxytocin, or maybe instrumental delivery like vacuum or forceps. I told for you that this day, the previous lecture, I think, when I deliver this section, I told that vacuum now is preferable than forceps applications. Primary and secondary in inertia also we can have, we told already for classification that is normal uterine polarity. So in between contraction, we have a patient has resting period is good, but primary contractions, contraction is ineffective, weak, poor from beginning of process of labor. It's congenital weak uterus. Possible do correction with infusion of oxytocin. If you have secondary inertia, I also told for you about that from beginning everything was good, but after that something happened and contraction decrease intensivity or might be stop, arrest or might be arrest of or decline of contractions. And in this case, always we need think about cephalopelvic disproportion. If in beginning was normal, after that suddenly, just rule out CPD. And here we can use different method. You can check and do it's present like care method or Vasten symptom. We can check. Please open after lecture topic cephalopelvic disproportions and pay attention for this test by which we check CPD. There's one with vaginal examination, another external Vasten and care symptoms we can check. And if we rule out cephalopelvic disproportion, in this case, we can try oxytocin. But if CPD present, in that case, is best way is C-section. If doctor doesn't rule out CPD and start oxytocin, what it can have? What's the matter? What can happen?
You can a lot of contractions and then it's not going to happen. So like
No, any idea?
a lot of contractions and then it's like contraction.
We have cephalopelvic disproportions. Contractions stop. Doctor doesn't notice this cephalopelvic disproportion and start infusion of oxytocin.
Could there be injury to the fetus during delivery?
No, injury not. А вот injury of uterus, yes. Because if something narrow, so we have several results. One result might be it's not effective, is the best if it's not effective. But it might be effective because if doctor try not enough, can increase number of drops. It's not fairy tale. I had I participate in recension like expert of such case when quite experienced doctor. I even study so much when I was post-graduation. I study from him so much. He's very good. But I don't know why he not estimate, not notice this. Might be because pelvis was not so narrow, not extremely narrow. Fetus was not so big, not 4 kg. It was 3.9 or 3.8. But this combination, little bit narrowing of pelvis, but little bit big fetus, he not rule out CPD, he start infusion of oxytocin and he get rupture of the uterus. It thanks God that he, and for sure distress of fetus, severe hypoxia, severe distress. It thanks God that he is very, как это сказать, good doctor. He is very experienced doctor. But even experienced doctor has, he is diagnosed, suggests this rupture very fast. He did mistake, but he finds this mistake. So he immediately take her for C-sections, deliver fetus, thanks God alive, but because he do it all these things fast, he is able to save fetus and mother. But because of previous non-realizing CPD, he get rupture of uterus and severe distress of fetus. Understand that? And thanks God, he is because he is very good doctor. He able even restore uterus. It was very big rupture on the lateral side of the uterus, till from cervix till tube uterine angle. he makes usually restore and preserve uterus because of his good qualifications and experience. Understand? So topic of abnormal uterine contraction is very important, is very interesting. And it's take not only physiology, it's take management, we need to understand. And for sure, again, remind for you, your daughter is not gave for you information. You can after that refresh with the help of Duta. When I read this topic in Duta, I not understand anything what he is explaining. So I decide to lecture about that topic, which is more clear, more informative. Поэтому please pay for that attention if you want get positive, if you want be a good doctor, first of all, if you want have adequate sufficient knowledge, please follow my lecture, not only our department, because it's update quite common, especially this topic, because some topic is plus minus is given good in your books, and it's not against, I say please, okay, you can read, but for that topic I always underline, I don't like this topic in your book. Do you have questions for me?
Madam, is it
Yes.
possible I can get a copy of the lecture?
Copy of the lecture, конечно, you can record while I'm reading, and you can listen it as lullabub every night. Not a problem. We translate is with the help of Zoom. I think you already quite well know, and I always remind for you that, okay, if you're not able, please record. It's not a secret. Record and listen if you forget. You can make photo from the screen. You can write something. Welcome. Did you do recording, somebody? All hand. Who record lecture?
I took pictures, madam, but
You took picture, okay.
yeah,
record.
I made a PDF.
PDF.
But sometimes sometimes the time is not enough to read all lecture. So sometimes we miss some part.
No,
Because the
this
time, like today, I don't know if today you read the entire lecture.
what lecture?
But some days, the time is not enough for the teacher to read the entire lecture. They always slides.
Madam, I recorded the lecture.
Вот. We find somebody who recorded. What's the matter? Enough time. You simply press button, да, and all what I'm talking, even how I scold you, is recording. Right? Right. Okay, so I can be only happy if you again refresh knowledge with the listening of lecture material. Так. Еще какие-то something not clear questions. How to record I not teach you. According topic, what is not clear, or maybe not according topic, use possibility to ask me something when I am with you. No questions. It's mean two things. All teachers say like that. Or you understand everything or nothing. It's miracle. It's miracle that you understand everything. So make a conclusions, logical conclusions that nothing. Ahmed, do you have questions? No questions. Okay. Все, that's all. Can say for you bye-bye.